Respected seniors and dear colleagues, a very warm welcome and good evening to all of you to this API meet for the month of March 2022. Today's session is being sponsored by Novo Nordisk, and the top is titled Improve Conclave, that's improving glycemic control with real world evidence. So we have a series of talks by experts in the field, and the sessions will be generally moderated by Dr. Rafiq Mohammed. I won't prefer to waste much time because we are already running late. So may I request Dr. Rafiq to please take over from me and initiate the session. Thank you.
Good evening to all. I won't waste time. We have a plethora of eminent physicians here who is going to enlighten us on how to improve patient control of diabetes. It's a real world evidence. This is organized by API but co-sponsored by Novo Nordisk, and we have just a minute. Yeah. So we'll go on to the first speaker. Will be Dr. P. Ramakrishnan. I don't think Dr. Ramakrishnan needs any introduction. He's the most senior physician here. So Dr. Ramakrishnan, will you please start off, because we'd like to not waste any more time. Thank you. The chairperson for this session is Dr. Shyamala. Will you please join me on the dais, please? Sorry.
Good evening, colleagues. It's just a warm-up before the big match is going to happen with all Virat Kohli's judges are going to bat. This is only a small attempt to focus on one aspect of diabetes management, especially when you are planning to introduce insulin, especially in new patients. You know that my journey with insulin dates back to almost 40 years, and I have faced the same problem at that time also and now also. Previously, I thought that it was because of the lack of knowledge by the patients. But now I feel that it is more knowledge among the patients is responsible for this fiasco. You know that it was a birth of idea almost 100 years back when insulin was invented. Since then, it has been the backbone of any treatment as far as diabetes mellitus is concerned, whether it is type 1 or type 2, and it has revolutionized the management of type 2 diabetes mellitus. But changing attitude towards insulin therapy is the most important thing, and a new terminology has come. All of us know that the pathogenic factor in type 2 diabetes is either insulin insufficiency or insulin resistance, which is physiological. But now a new terminology has come, psychological insulin resistance. Very important terminology now, which we all are facing it. Now, why do patients avoid insulin therapy? Understanding the barriers, and we should address the patient's related barriers for insulin initiation and approach effective insulin. I am just making a small attempt to draw into some of the points which I have experienced in my life as a physician in day-to-day practice. This is what we call as understanding psychological insulin resistance, PRI. Insulin resistance can be defined as a physiological opposition towards insulin use. It represents a complete set of belief about the meaning of insulin therapy, poor self-efficacy, concerning the skills needed to insulin therapy, fear of injections, and a basic inaccurate information. If you look at the studies here in NEGM and other things, you will find that almost 30% of the people refuse to take insulin, despite the knowledge that insulin is the mainstay of diabetes treatment. You can say psychological insulin resistance is very common. Almost 30% of the diabetic patients refuse to take insulin either at the beginning or even at the later stage. What are the attitudes of a patient if they take insulin? taking insulin leads to poor outcomes, including hypoglycemia, weight gain, and complications. Means the patient's disease is worse. There is a feeling that when you ask a patient to take insulin, he and his relatives feels that his disease has become worse. So an attitude means the patient has failed in his own management style, like diet, exercise, or with oral hypoglycemic agents. Means life will be more restricted. If you take insulin, your life will be more restricted. Means people will treat the patient differently, will not make diabetes easier to manage. So these are the attitude of the patients when you ask the patient to take insulin. Now, additional factors associated with this resistance in individuals, of course, fear of hypoglycemia is there, gender difference. I think it is more in women because of the sites of insulin injection is very much important for them. Then ethnic problems, I don't know anything about ethnic. So these are the common barriers. Now, what is the impact of this psychological resistance? It can worsen the existing diabetes, increase the complications of diabetes, and mar the lives of even a young patient. Now, how do you assess the patient barrier or the different psychological insulin resistance? Of course, I need not go into details, you know all about it. Now, how to prevent these strategies? I need not tell you that education is the most important thing as far as managing this resistance. Confidence building in the patient is very, very important, and skill development among the patients, how to manage diabetes by themselves. Now this is just statistics to show that how much a healthcare professional can assist in overcoming this psychological resistance. Especially this study has shown that 3 factors like demonstrating the injection process to the patient, explain the insulin benefits, and collaborative style with the patient can overcome this insulin resistance. Now the solutions are a good insulin start and stay. Effective insulin conversation is the most important thing than prescribing just an insulin dose or a pen or other thing. Effective titration of the dose is also very important. Very, very important when you prescribe for the first time insulin to a patient. Education, including setting expectations that if you take insulin, your lifestyle, your lifespan is going to increase, and follow up and support. Just not writing the prescription and just leaving the patient to have his own insulin pattern. Now, effective conversation is the key. Unfortunately, in our busy practice, we tend to forget this important thing in our practice style. Start insulin conversation shortly after diagnosis. Even if you don't give the plan to start insulin, start a diagnosis of insulin that you may need insulin, which will be worthwhile to control your diabetes. So start from the first diagnosis itself. Ascertain how the patient feels about the insulin, even at the beginning of the thing. Explain and educate the benefits of insulin. Solve problem with the patient. Patient may come to you with many problems, but try to solve it at the outset and develop a plan together with the patient, not leave the patient alone, and set expectations to the patient that he can have a good, comfortable life in the future. Now, these are some of the concerns the patient may give to you. Taking insulin means have failed to manage diabetes with diet and tablets. A question of guilt that despite these tablets and things, I have failed to manage insulin, diabetes, and that's why my doctor is asking me to take insulin. But you have to tell them that diabetes is a progressive disorder. Insulin is the most natural management of diabetes mellitus. They have not failed with their diabetes management, but diabetes needs frequent changes in the treatment schedule, and alleviate the guilt and increase the motivation among the patients. Second question is, taking insulin makes it more difficult to fulfill my responsibilities at work and home. This is a very, very important thing. Many of the patients explain this thing. It is cumbersome, but tell them that insulin will decrease the sick days and make one more active than before. Newer insulins with flexible regimes make it easier than before. He or she can take part in every job, be it at office or home or travel, a motivating factor. Again, third factor is I am afraid of injecting myself with needle. Very, very important thing, but you have to convince them that teach the injection technique, show the pen and size of the needle. And now you have got different types of pens and needles have become smaller and smaller. Even you won't even feel a prick of it. Demonstrate the injection process in clinic to build confidence. This is again one of the most important things. When you prescribe insulin, ask the patient to bring the insulin kit and teach them how to do it in your clinical room if you have got time. Unfortunately, even that is not happening in our busy schedule. One drawback as far as a big practice comes. Assure the patient that the insulin injecting process is very, very easy. Another myth, taking insulin increases the risk of hypoglycemia. Very well said. Every patient is bothered about it, but you know that hypoglycemia can be tackled easily. You know, if you can talk to them about the symptoms of diabetes, hypoglycemia, that it can occur even with the OHS, and explain the symptoms and how to tackle it. That is a very important factor when you prescribe insulin to a patient. This is again a bit lacking because hypoglycemia is still the factor which is not even talked in meetings. I think almost 15 years ago there was a talk on hypoglycemia and never I heard anything talking about hypoglycemia. Just for people, hypoglycemia even for doctors means a 25% glucose injection, nothing more than that. But you know hypoglycemia can cause so many things. It can produce acute renal shutdown, cardiac arrest and all the things. It can mar the life of patient. But let us give more attention to the patient, inform him about the symptoms and signs of hypoglycemia and preventive measures. Insulin causes weight gain. This is again very practical thing. All of us, those who are on insulin, know that it can increase the weight gain. But if you can tell the patient that insulin is an anabolic hormone and some degree of weight gain is expected, even with sulfonylureas, you can gain weight. However, newer insulin analogs, very important thing, newer insulin analogs shows less weight gain. Very important. We have got a lot of insulins and balanced meal plan, adequate exercises help you to manage your diabetes and weight. And if you can add some other OHS which can reduce like SGLT2 or metformin, it can still further decrease the weight gain, 1 or 2 kilogram of weight gain, which may be induced by insulin injection. Taking insulin means life will be less flexible. Explain and eliminate the negative strategies. Explain with empathy. Examples, I tell you, my first example is Wasim Akram, the famous Pakistan cricketer whom I have given insulin injection in a Bombay test match. Even after 15-20 hours before lunch, he comes to the pavilion and takes injection. There are so many examples like Sonam Kapoor, Kamal Hassan, Nick Jonas, and Wasim Akram. If you can explain to the patient that even the bigger celebrities are taking insulin with their own jobs, it will be an impetus for the patients to take insulin. One more important point when you prescribe insulin. Managing insulin injections take a lot of time and energy. Provide adequate training and support to empower self-management. And self-injecting insulin is simple and fast with newer insulins and their devices. Taking insulin means I must give up activities that I enjoy. No, tell them that you can have all the activities. You can run, you can do yogas, you can go to exercise, you can play any games. There is nothing to worry about it because important thing you should that. And overcome the stigmas. This is also very, very important. Involvement of other patients who are at peak of psychological well-being on insulin. The example should be given to the patients. Taking insulin means other people see me as a sicker person. This is very important. When a patient starts taking insulin, there is a stigma among even the relatives that he is very sick and the patient is looked upon as a very sick person and lost his life activities. That is where the family education, the relatives should be taught that insulin is not a bad thing. It increases or improves the well-being of the patient. Being on insulin cause family and friend to be more concerned about me. That means they will consider you as a sick person. No, you tell them that you will see him as a better balanced person. This is the message you should give. Taking insulin helps to improve health, because it is not it is the identical natural insulin that the body secretes. Only thing is you are giving it from outside. Exogenous insulin will execute the same physiological function as the endogenous one. This is a very important message we should transfer to the patient. Taking insulin prevents complications. This is again one more important thing, that you should tell the patients that if you put on insulin, even with other drugs, this prevents the chances of getting into complications like heart attack, neuropathy, kidney failure and other things. And this message will give an impetus to the patient to take insulin by himself. This is the message I always want to tell you. Insulin is a remedy primarily for wise and not for foolish, whether they be doctors or patients. This is a very important message I would like to give. Insulin is a remedy primarily for wise and not for foolish, whether they be doctors or patients. Everyone knows it requires brains to live with diabetes, but to use insulin successfully requires more than brains. This message is again to the doctors as well as the patients. So takeover is same thing. Insulin is not harmful. Understand the patient's barriers or concerns about starting insulin. Start the insulin discussion early to the patient. Explain why they need insulin and provide information on the benefits of insulin therapy. Provide a sense of control regarding insulin therapy. To increase their confidence before starting the injection, give the patient time to try the insulin pen and medicine. One more message I will tell you. Now we have got many types of insulin which can be taken just with meals, just 15-20 minutes after meals. So previous concept is gone, half an hour or 45 minutes and other thing. Or you can take one injection at bedtime. So this will not affect any activity of the patient. And if you can impress the patient on these facts, I think insulin still is going to be a big weapon in our hands to manage diabetes successfully. Thank you very much for your patient hearing.
Thank you, Dr. Ramakrishnan, for a very effective and short talk. You have addressed the patient's psychological resistance. But what about the physicians? I think that's also an important part on the other end of the spectrum. Physicians also have a psychological resistance towards starting insulin. That's what I have felt. I mean, including me. Anyway, any questions? Any comments, any experience? Let me just put, I mean, you have already covered it, but just a hypothetical scenario which we come across. An actress, past her prime, comes to you with uncontrolled diabetes. She is very conscious of her figure, and you convince her about about taking insulin, and she takes for 3 months. Her diabetes is under control. The physician is very happy, but the patient is not, because she has gained weight. So what will your approach be? Option 1, you will convince the patient that it is an anabolic hormone and ask her to continue it. Second, I mean, of course, that is the best. But second, any other option will you offer her?
Certainly, first thing what you said is, this psychological resistance is more on the part of the physicians. It is happening because, to be frank, there is a chance that you may lose the patient. In the practical aspect, I will tell you, there is a chance, every chance that you are going to lose a patient. That is why I said that never, unless and until there is an emergency, do not go for insulin till you convince the patient that these following drugs have failed to decrease your blood sugar and you may have to have insulin. So give him time to get adjusted to this fact. Number 2 question is, actress. I told you about Sonam Kapoor. She is still on insulin. And as I told you earlier, insulin, whether you say anabolic hormone and other things, is not going to increase the weight more than 2 or 3 kilograms. In your practice, you will see, even thyroid hormones can increase the weight. Not hypothyroidism can increase more weight than an insulin-taking patient. So you have to emphasize that along with insulin, insulin is not the panacea of all diabetes mellitus. Along with that, you should have a diet plan, meal plan, as well as dietary schedule, and some of the additional drugs, as I told you, like SGL2 inhibitors or a metformin, can compensate the small weight gain which the insulin can come. So I don't think, in fact, what you said is correct. I have experience of 3 actors and 2 actors still on insulin. They have asked these questions, but I don't want to name the actors, actresses who are even now in the limelight in the news. She is still on that. And a famous actor who still maintains his body, very young actor, also is still in this with insulin, long-acting insulin. But they also expressed this problem, but I said that you can manage with your gym and other things. There is nothing like that. So it's your approach to the patient.
Any questions from the audience? What about the GLP-1?
Yes, GLP-1 also is supposed to decrease the weight gain. It can alone be used. I am only talking about when you are planning to insulin, because at any time of your life you may have to use insulin. So that scenario is more important. If you add GLP-1 and other things, it will further decrease the weight gain. That's all additional drugs.
There are no more questions. I think we'll thank Dr. Ramakrishnan for an excellent talk. I think we'll go on to the next topic.
Excuse me, may I request Dr. Shyamala Menon to present the memento to the speaker, Dr. P. Ramakrishnan.
Thank you, Dr. Shyamala.
And Dr. Rafiq sir to present the memento to the chairperson, Dr. Shyamala Menon.
Thank you, Dr. Ramakrishnan for an enlightening talk, and Dr. Shyamala for interesting comments and questions and things.